Hello, my name is Dr. Nigel Watson. I'm a GP and Chief Executive of Wessex Local Medical Committee. This is the second part of our blog related to the workforce. It is often said that many newly qualified GPs are leaving the country to work abroad and will not return, and are therefore a loss to the profession. During the review, we've heard from GPs who've worked abroad for periods of time and used their profession as an opportunity to travel and experience the life and cultures of different countries. While some UK-trained GPs can work abroad for short periods of time and return relatively quickly, for those who've been working abroad for more than 2 years, the return can be more challenging and involve significant effort, cost and bureaucracy. Whilst it is important to have a robust system in place to ensure GPs are suitably qualified and experienced for their challenging role, it is also a positive step that government, with the GMC and others, are considering ways in which the process can be streamlined and simplified to support the return of GPs to general practice and primary care in this country. The review encourages the ongoing action to continue this process of simplification. Building on primary care networks, perhaps we should consider some deferred roles so that GPs have the opportunity to work abroad for a period of time and can return to a post in the UK. Or potentially, in a similar way to some hospital specialties, develop some 3-year primary care fellowships, which include a year working abroad in a different country. Changes to the annual and lifetime allowance for pensions have had a significant impact on GPs as relatively high earning professionals. However, during the course of the review, many have said that these changes are leading to significant personal financial impact, even for those relatively early in their careers. And pension tax changes are commonly cited as a factor for GPs who are deciding to reduce their clinical commitment, retire prematurely, or opt out of the NHS pension scheme. These perverse incentives for experienced GPs to reduce sessions in order to reduce their exposure to additional tax charges represents poor value for the system, given the relative high cost of training GPs and the increased cost of locum cover to backfill GPs' capacity. Greater flexibility in the pension contributions, in line with the flexibilities available to members of other public sector pension schemes, would support some GPs to remain in practice for longer. The government should urgently review the current arrangements to determine what additional flexibilities could reduce the negative impact on retention of both partners and sessional GPs. We know that ultimately 50% of medical students will become GPs, and for those working in other specialties, gaining a knowledge of how general practice fits into the local healthcare system is becoming more important as general practice, community-based care and hospitals work together more collaboratively. It is therefore important that medical students should spend more time in general practice, and the tariff reflects the true cost of delivering this and doesn't discriminate between general practice and hospitals. All foundation doctors should spend some time in general practice so that they can gain a broader understanding of how general practice is a vital part of the local healthcare system. It would also be beneficial if some relevant specialist trainees spend some time working in primary care. This is important as we develop more integrated care, especially in specialties such as diabetes, respiratory care, cardiovascular, and care of the elderly. We have recruited more GP trainees than ever before, and we therefore need to expand the number of training practices. During the review, we've heard that the process of becoming a trainer or a training practice can be seen as unnecessarily burdensome and inconsistent. It should therefore be simplified and made more consistent, and encourage more practices to take on this important role. All primary care networks should become a training hub or be part of a training hub to enhance the place-based training of a wide variety of healthcare professionals. If we're going to meet the workload challenges within general practice, we need to expand the capacity and therefore expand the workforce. That's not just looking at GPs, but other staff that can provide direct care to patients. These should either be based in practices, or if they are within a primary care network, need to be embedded in general practice. The role of the advanced nurse practitioner should be developed to help with the direct management of patients with long-term conditions and minor illnesses, as well as urgent care. Pharmacists can play an important role in practices, supporting the care of patients with long-term conditions and minor illnesses, and also they've been shown to address issues to do with polypharmacy, care homes, medication wastage, admission and discharge medication, increasing the uptake of electronic prescribing. There are benefits to practices, but also there are benefits to the local healthcare system with significant savings. For example, West Hampshire CCG showed a return on investment of £2 for every £1 invested in practice-based pharmacists. A musculoskeletal therapist based in a practice can not only be the first point of contact for some patients with an MSK problem and therefore help with GP workload, but also have reduced referrals to hospitals, reduced the number of diagnostic tests and medications prescribed. There is also potential for a comprehensive musculoskeletal service to be based in a primary care network, which would include community physiotherapists. Mental health is a major issue for the NHS, and the workload associated with this has increased significantly recently. There has been much focus on the crisis intervention and the burden on accident and emergency departments. However, there remains a significant gap in the provision of adult and older people's mental health services in the community, and this has had a major impact on general practice. Further development of the community psychiatric nurse role could bridge the gap between general practice and mental health services. Consideration should be given for a number of posts to be established where there is time spent in both general practice and also within a community mental health team. Other NHS staff such as paramedics, care coordinators and social prescribers would make a positive contribution not only to the practice workload but also to the health of the population. This will encourage a wider scope of practitioner working together to enhance the service provided to patients and prevent professional isolation. This is based on the assumption there will be sufficient supply of members of the workforce, and therefore efforts need to include ensuring that there are an appropriate trained workforce in general practice and that these are available in sufficient numbers. Further training and development to support practice managers should be rolled out. Better equipped practice managers could make a significant difference to the current workload burdens, enabling partners to take on a more strategic decision-making role, while a business manager oversees the day-to-day operational running of practices. Training should be linked to the development of primary care networks and staff funded as part of the long-term plan for the future of the NHS, and this should be accompanied with a workforce strategy. Practice nurses play an increasingly important role in primary care, particularly in the management of long-term conditions and urgent care. This should be recognised with an agreed programme to develop these roles, with funded training and increased targeted investment that will make a real impact on the expansion of the nursing workforce. This could include the equivalent of a trainer's grant for nurses placed in practices. The long-term aim should be to develop an integrated nursing team which includes practices, district and specialist nurses. Multi-professional community health teams should be based in primary care networks and work under the clinical and service direction of the leadership team of that network. They could remain employed by their existing employer while being more closely partnered with and embedded in practices on a day-to-day basis. This should include the creation of a single team using a common health record, sharing the same caseload, removing the need for referrals. And wherever possible, the community team should be co-located with the constituent practices in that network. NHS England, in partnership with other bodies such as training hubs, need to support primary care networks and community health services to work together more effectively and become more than the sum of their parts. In conclusion, we know that the workload is increasing because of an ageing population and more patients have one or more long-term conditions. In the past, we've been too dependent on hospital-based care, and there needs to be a greater focus on delivering care in the community. General practice has to play a significant leadership role in this development, and the workforce needs to be increased. We need more GPs, more nurses, more clinical staff to support general practice, and we need to make more effective use of existing resources.